started?
Yeah, I think so.
All right. Hi, everybody. I'm just going to do a quick land acknowledgement to kick us off, and then I will hand things over to Shannon. The University of Washington acknowledges the Coast Salish peoples of this land, the land which touches the shared waters of all tribes and bands within the Squamish, Tulalip, and Muckleshoot nations. Thank you all for being here. Let's get started.
Wonderful. So thank you to anyone who's actually here to join us for talking about fidelity and adherence. I'll do quick introduction so we can move into the content. So I'm Shannon Dorsey. I'm a professor in psychology, adjunct in global health, and I'm an implementation scientist and a treatment effectiveness researcher. And a lot of my work is really focused on how do we deliver high quality interventions in settings with limited resources. So that includes both community mental health and publicly funded mental health in Washington State and the US, as well as countries who don't have a large mental health professional workforce. So I'm really excited to talk today, and I'm mainly excited to present with my primary partner in all fun things, Chombalelo Mukunta Chisenga. So she has more than 15 years of experience in the field of mental health. She has a master's in counseling and psychology from the National School of Leadership. She's been involved in some of the most important trials of child-based interventions and adolescent-based interventions, as well as some adult ones, and really ensuring that counselors do high-quality work, feel good while they're delivering it, and clients get better. So we're really excited to talk with you today. All right, so we're going to be talking about building a robust plan to support and evaluate intervention, adherence, and fidelity. The reason I called it adherence is fidelity is a bigger construct, which I'm going to talk about, and mainly what we're going to focus on today is adherence. So these are the goals of the talk, and about half of the talk I'm going to focus on sort of the science of adherence and fidelity, and then the second half we're going to take you through active elements of how we do this with Chombalelo and myself, mainly demonstrating through role plays where I'll be the counselor and Chombalelo is the trainer and supervisor. So we'll start with the first part, which is how to support fidelity. If you want to have good adherence and you want to have high fidelity, you have to both figure out how to support it, and then on the other hand, you have to measure it to know if you achieved your goal. And I'll start with the support part. So we have long known that if you want good client outcomes, those relate to both our interventions, but also our implementation of those interventions. Too often we try to take up interventions that have fabulous effectiveness and look great in our trials, but we don't do the same things or approximate things in our implementation when they go past the trial. And so sometimes if you look at some of what we saw for interpersonal therapy or friendship bench when they were first moved from the primary implementation to later, you saw this voltage drop in effect size. And in part, it's because we don't always carry forward that implementation. That's less true at UW because we have fabulous implementation science researchers here who focus on that kind of thing. But that's what I'm going to talk about is how do we make sure if you choose a fabulous intervention with effectiveness, we make sure the other things come along with it. So what is needed to support fidelity or adherence? So adherence is one part of fidelity. If you want some of the papers that summarize all the parts of fidelity, I can send those. But I'm mainly focused on the piece of fidelity that is adherence. Was it delivered as intended? So the things the counselor was supposed to do, did they do those? And you'll see other terms like treatment integrity sometimes used. I'm not going to talk about competence and quality because we have limited time. Competence, how skillfully you deliver the intervention, is much harder to measure. But we can talk about that. In our work, we've tried a simplified version, which I'm happy to share, but I'm going to focus on adherence given our more limited time. So I don't know if people have seen this paper by Bryce McLeod and colleagues, but it really maps out a conceptual model for how training and consultation or supervision lead to fidelity and to client outcomes. Unfortunately, in the real world, most people think of training as the essential piece. But look at training. It's just one tiny piece of this, right? And the outcomes under training are declarative knowledge, their initial acquisition. It's the consultation and supervision that translates training into actual practice. They use the word automaticity. I would say action. When does it become automatic that you know this intervention and you can deliver it and you can actually expect positive client outcomes because you really know it and you're doing it as intended. So given that they use treatment integrity, I've tried to pop under there fidelity so that you can see the outcome if it's not hidden on the front slide. So what do we know about training? Unfortunately, training is necessary but not sufficient. So people talk about training as train and hope, train and pray, like you really hope it's enough, you pray it's enough, but we know that it's not, especially for interventions with many elements or skills that need to be learned and delivered well. I'm actually not sure what intervention doesn't have some skills that need to be delivered well, but I'm talking about the strategies to ensure fidelity. On the treatment redesign side, I think we also need to develop treatments that are much easier to deliver so the fidelity support doesn't have as high of a bar, but that's one of the things to think about. So problem-solving therapy is a treatment that is one element, problem-solving therapy. It still has many, many steps to do it well if you know that intervention at all. But then we have other interventions, like one I deploy a lot with great evidence, trauma-focused cognitive behavioral therapy. It has, welcome y'all, thank you for coming. We had some people pop in. I'm glad to pop back to the old slides later. Very fun for in-person events when you have some people come in person, so thank y'all. So trauma-focused CBT, look how many elements trauma-focused CBT has. So even just relaxation has maybe 12 to 15 steps. So if you want to support fidelity and teach someone to do these things well, think about how much you're actually learning here. So you're learning each element, and then you've got to learn to deliver it well. And then on top of that, oh, I thought I was going somewhere else there. Hold on. On top of that, I'll come back to that just a second. On top of that, you've got individual differences in clients, which I'll come to. One thing that people have said about training, and there's a cartoon that I don't use any longer, but the quote from the cartoon is, "I'm back from the training. I got this big binder, a living monument to temporary knowledge." How many times have y'all been to a training on anything? This is great. This is fabulous. On the shelf. Doesn't mean you always come back to it and use it. So we know with adult learning that training alone is not sufficient. You have to get the support to put it into play. So to actively support adherence, we need support that follows training, that helps trainees practice what they've learned with guidance, coaching, and feedback, and helps them really convert that knowledge into action. And lay counselors and community members and paraprofessionals who often help us meet that mental health treatment gap, they really need the support after practice, because even the idea of doing a mental health therapy or an intervention may be new to them. Paul Bolton, a colleague of mine at Johns Hopkins, really calls supervision training part 2, because he thinks partners then really see it as essential. So training part 1 is when I teach you the skills, or Chombalelo teach you the skills. Training part 2 is when you're practicing with an expert who coaches you through it, meaning that you can't drop supervision, but you really have to have that as part 2. And I would say it's as essential as training, and maybe more so. I'm not sure if Anna Mbwayo is on here, one of my colleagues at the University of Nairobi, but during COVID, we did a very fast training that we did on using WhatsApp and using Jitsi on the phones, and we did more close supervision, and that was fine. So we could do a light touch on the training because the supervision was where they were really putting it into play. And I'm glad to send you her paper if you'd like that. So just stepping back to the training model again, reminding ourselves that consultation and supervision is necessary after training. And there are other reasons for that. Here's the one I thought I was going to a moment ago. So in addition to how complex an intervention is, every human, client, patient is different. So you may really get how to do relaxation, or you may really get how to do thinking in a different way. But then all of a sudden you have a very reserved older teen who says nothing. You have someone walk into your office who does not believe in therapy. How do you get them involved? You have an extremely depressed client, and all your practice or in the training, you didn't focus on people with active suicidal thoughts. You focused on people who were mildly depressed. Maybe you got a man with past trauma. You're not treating trauma, but how do you think about the trauma that's going to come into the therapy room when they're treating depression? So you can see with all the examples I have here, that training can seem simple. You can think you've got the intervention till someone walks into your room and you need to actually tailor that intervention to fit the client. And we know that we want you to have fidelity and adherence, but we don't want these to be one size fits all, because on the past slide, the grandmother who didn't go quite as far in school, if you try to do everything from writing, is she going to receive that intervention? No. So you've got to think about how do you have adherence and fidelity, but tailor it. And with consultation and support, the provider or the counselor gets a chance to practice how do you still deliver with fidelity, even if you can't use the worksheet you thought you got to do. How do you deliver it with the team who maybe doesn't talk as much and is pretty reserved, but still deliver the elements? Because otherwise, what do you imagine a new counselor might want to do? Kind of throw it out, right? Like, yeah, good. Celine's like, they might want to just toss it to the side and do something different. You need a lot of support to figure out how to do these interventions with different types of people. I think some of this is true still with injections, with medications, with other routines, because some people are going to be more or less involved and able to like take it up readily in your office visit. But for mental health interventions where it's a talking therapy and it's an interaction, you really have to support counselors and give them time to be ready to deal with whoever kind of walks into their room. So again, what we really want is we want to move from initial acquisition and training all the way to automaticity using some form of post-training support. And that usually looks like consultation or supervision. So clinical supervision and consultation are implementation strategies. They're in Byron Powell's Eric's list of the implementation strategies. And it's essentially having someone with more experience supporting your work in practice and application to clients. So let's talk about practice. How many of you would like to be someone's first client? They learned a new intervention. How many of you are signing up for that? Pam's signing up because she's a scientist and she is happy to take that chance. You know, often you can be really good with your first implementation of an intervention, especially if you're already a mental health provider and you've done similar things. But everybody benefits from a little practice before you try to apply a new skill to your client. And for many of our trainees who are mental health therapists, they do have a first client. But did you have a lot of practice? I'm looking at one of our PhD clinical students. Yes. Anthony, did you have a lot of practice before your first? You always need to practice, right? And this is especially true if the provider has never done mental health therapy before. So a lot of our work globally and a lot of our work to expand coverage in more rural areas, Teresa Hoft here and others have done a lot of this work to use lay or community providers. If you've never done a mental health therapy before, you really need a lot of practice so that we can ensure, first tenet we have as mental health providers is do no harm. So we have to make sure that they could do the intervention in a way that we expect the client would get better. And that takes some practice. And if you think about sports games, how do players learn? They don't end up on the field in the competition the first time. You can see the coach kind of pointing to the young player. You talk about it, you practice on the field. Okay, pretend like someone's going to cut in to the right. Now run out there and try to get the ball, right? You're practicing under real world conditions in sports. And so that's a nice analogy for this. You don't send someone out to the World Cup game or even to the division finals or even to a match if they haven't actually practiced first. So that's one piece that you'll hear a lot about when Chombalelo begins is that we have this nice phase of practice even before you see a real client. So we've published on what we call the apprenticeship model, and this guides a lot of our work, but I wanted to show you how we think about some of this flowing over time in actual practice. Nobody's has to look like this, but it's just one of our examples. This was from a project in Colombia with displaced and violence exposed Afro-Colombians. So we have the in-person training. That's the smallest thing on the slide, right? And time marches from left to right. You can see Skype on here that tells you how old this is. So the first element of our post-training support is practice groups. We had lay counselors from the community who were going to treat other community members. And so they practiced, and Chombalelo is going to lead me through as one of her new counselors, a practice session. So they practice without real clients, just doing role plays in small groups. Pam Kohler, who some of you may know, has done a lot of this behavioral rehearsal work. And so this is a huge strategy that you can use when you're not going to harm a client if you get it wrong. And also there's the way you say things when you're a new counselor. If your client stumbles, and in our practice sessions, we make up a client who will stumble. At first, a counselor might just say, no, that's wrong. Don't do it that way. And in therapy, that's kind of hard. You got to find a way to say, lots of people make that mistake. But here's another way to try it, like to try to do it in a way that feels good. So first it's practice groups. Then when you start seeing cases, We tend to have this second phase of where you just get one client, you get a lot of close supervision because you can learn a lot from that first client that then informs the third phase, which is underneath that is study client. So this was a study and this is when the study started. So in the third phase, now that you got really close supervision with one client, you can start building your caseload. You can take on another one, another two, and keep building because the lessons you learned with that first client really pay off, but you still need closer supervision at the beginning. And then you can kind of see the time marching at the bottom. I will fully acknowledge some of this needs to be speeded up. The science isn't quite there for how to speed it up super well and hold quality. So I'm definitely erring a little on the quality side with some of what I'm showing you today, but we have some thoughts about speeding up that I can share. So coming back again to our two treatment examples, you can imagine that time might be speeded up if you had one element. But if you want to treat every, say, mental health condition, you want something that treats trauma, depression, anxiety disorders, behavior problems, and you have something that has more elements, or you want a trauma-focused intervention, then that time is probably going to be a good bit longer. So people are working on different ways that you can think about post-training support. It really can take various forms. Again, it's usually supervised practice, then supervised delivery. Shannon Wiltsey-Sturman is actually doing a lot of this work. In that post-training support, often it's a lot of practice and next less preach. Shannon Kate Veerman has this great paper that has such a fabulous title, More Practice, Less Preach, which is where when you think about supervision or that post-training support, how is it the counselor really trying out the skills as if they were with a client and getting feedback from the expert? It's not just talking about the treatment, because people can talk about an intervention and it doesn't mean necessarily that they can do it very well because they don't get to see a client misunderstand things or make mistakes. One of my students, Rosemary Mesa, has done a paper looking at clinical supervision and if it predicts client outcomes. And in her paper, predicting fidelity in this one, in her paper, the style of supervision, so whether it was more active, really predicted fidelity. And so that can really make a difference, not just saying we need supervision, but what does that supervision look like? So we've developed a lot of guidelines for behavioral rehearsals. Pam, I think, has a lot of this work as well. It'd be neat to think about what we can pull back from other studies that anybody can use. But the idea of the role play is really that you can see the counselor's adherence and competence in an interaction as if they were with a client, but you're not harming the client yet if they make a lot of mistakes because they're doing it with someone as a practice. So we have some of these, they're freely available for trauma-focused CBT and glad to share them. But it really involves a prompt where, you know, the counselor, you're saying, show me how you'd introduce this concept and apply it to a situation in the client's life. Okay. I did want to bring up this paper. We made this paper as useful as we could a few years ago. It has a bunch of supplemental materials that show example role plays, even videos of how to do them across a bunch of different treatments. So if you're interested in looking at behavioral rehearsals, this could be something to check out for additional resources. Okay. So I was mentioning that time at the bottom and how much time is needed. And is that too much time for some projects and studies? It really might be. What I've been thinking more about across doing this across a few different projects is we kind of need to have this back and forth dialogue between how much time do you have and what kind of intervention do you want and what resources do you have. So it seems like how much time providers have and their experience can determine how long it takes them to really get to a proficient level of adherence or fidelity. And on the right side, you've got folks who maybe have more time or already have mental health experience. They might be much easier to get up to speed. But on the left side, the more I've been working with folks in HIV clinics at the University of Washington, the University of Nairobi, and Kenyatta, when an HIV clinic is already a very busy place, or US community mental health centers where people are overworked and underpaid, these are places where people already have full-time jobs. They're doing so many other things, and they're already need to be an expert on HIV treatment and HIV care. Fitting in that practice can be hard. So sometimes the time to get proficient looks so long, but it's because somebody only has, say, an hour or two to commit a week. We had some community health volunteers in Bungoma sub-county who, were doing 20 hours of their CHV work and had some other free time. They were actually able to dedicate a lot of time to practice and they got proficient pretty quickly. But they were able to do more time up front because of that. And that's not always true. So I think how much time we need might then change what intervention you choose, because the more complex interventions take more time regardless of setting. But then setting and context plays a role on how much time any one individual needs or any clinic or facility needs. Okay, so now I'm going to move into the second part, which is measuring fidelity. And then I'm going to turn it over to Chombalelo. My summary about the post-training support of what you need is really making sure it builds into your plan, considering the time, money, and resources you have, which might mean circling back to the intervention. And if you've got limited time to practice, just knowing your project or study builds in time for people to get proficient. And that all partners understand this process, because for someone like me, I'm used to it, but I've learned that if you're partnering with someone where it's new, it can be a shocker when you're getting started. Okay, so now I'm going to move into the second part. So probably measuring fidelity is what people are a little more familiar with. So I'll move through this one maybe a little bit more quickly. But Sonia Schoenwald has this great paper talking about how fidelity and adherence can be effective or efficient. So it can be rigorous or it can be really easy to do. And there's not a whole lot of things that are in the middle. And depending on the goal of your fidelity measurement, you might pick more ease of use or you might pick more complex. For a lot of our studies, I think sorry, I didn't mean to say complex, I meant to say effective or rigorous. For a lot of our studies, we really need that effective measurement, but yet in a lot of our contexts, it has to still be efficient. So one thing that we know about gold standard effective measures for assessing fidelity, including adherence and mainly adherence, they're almost all observation one way or the other. So it might be observing through recording, it might be watching something live through, a screen, it might be sitting in the back of the classroom and doing observation. And in many interventions, observation can go really well. We did an intervention in primary schools in Bungoma County, and our supervisors would sit in on part of the intervention, but they were around a lot. People knew them. They had permissions. It worked really well. The kids didn't think it was odd that they would sit in because they were the extra support, but they would sit in and rate. So it almost always involves observation, and it pretty much never involves self-report. Now, self-report is obviously one of the easiest and efficient measures of fidelity, but unfortunately, it's not always effective. So we've studied this a ton. And this is one of the papers that studies this that I'm involved in that I'm going to show you. But unfortunately, when you look at self-report and the tall lines are self-report, the small lines are direct observation, what the observer said was done is quite different from what the therapist said they did. So therapists, and there's another paper by Michael Hurlburt and lots of others, therapists or counselors tend to overestimate sometimes by 2.5 times what they did compared to what an observer witnessed. I don't think this is because therapists and counselors are lying. It is hard to reflect on your session, report what you did, and if something is new to you, how do you know how well you did it? You might think you did it really well, but an observer who's got real clear scores might see it differently. So unfortunately, self-report differs. We still all have to rely on it. Believe me, there's a lot of options where I think you can combine self-report with other things, and I'm going to show you one of those. But for high stakes situations, self-report is not very effective. So behavioral rehearsal is looking really good. I don't know if people have seen this paper by Emily Becker-Haynes, but self-report is on the left. You see how different it is from direct observation. A structured behavioral rehearsal they did was almost equivalent to self-report. And that's true for almost every single intervention. So when I showed you the slide before that had every single one, behavioral rehearsal is almost exactly the same. So it's holding a lot of promise for an option for like analog fidelity. We do a combined kind of behavioral rehearsal, self-report, and observer strategy, which you're going to see. Counselors do a self-report form after their session. Then they talk through it with their supervisor or trainer, like Chombalelo. The person like Chombalelo who has more expertise in the intervention asks a lot of questions, and they can then follow up. And then they use the counselor's report plus the discussion to use their expertise to make a rating for adherence and competence. And we've done lots of studies with randomized controlled trials using this approach where we have fabulous client outcomes. And so it seems to really be working well and take a little bit of a balance between effective and efficient. We do use a really close rating scale, and part of having raters do great on fidelity is having a really clear fidelity scale. So the way we talk about adherence with our counselors in training and in supervision is we're all making a recipe. We need to make it with the same ingredients. And so we have a scale that goes from 0 to 6. I'll show you the next two on the next slide. And that's what the supervisors or trainers use to rate the session through conversation with the counselor. But of course, they have to work together to give multiple trainers and supervisors to make sure they all rate in the same way. So you'll see more about this in just a second. And then I did want to put a plug in for this before I switch over to Chombalelo. People are looking at some other alternative options for assessing fidelity. So this is a grad student of mine, and then Shannon Wiltsey-Sturman again. They're looking at worksheets. So a lot of treatments that use a lot of writing, probably more in context where you know your clients have secondary education, or sorry, high school or secondary school, so that they can write and participate well in worksheet-based stuff. But you can look at the worksheets actually and tell how well the counselor understood it. So there's a treatment called cognitive processing therapy. They use a worksheet where you fill out these columns. So this is an example of a worksheet that was done well. Here's another worksheet. I was fired because I can't do anything right. If you saw this and the counselor hadn't helped the client fix it, it shows that there were some mistakes that, yes, maybe the client didn't understand, but the counselor didn't know to correct it. So this includes an automatic thought, which would go in the beliefs column, not here. And then also in the beliefs column, it also includes an emotion, which should go in the other one. So in their study, they actually use this approach to assess fidelity, and it performed very well compared to direct observation. So I'm just putting in a plug in for that one. I'm not sure we're ready to use that for a lot of our lower resource contexts where there's not as many worksheets, but it's a really exciting direction. Okay, thank you very much. And I'm going to be turning it over to Chombalelo. Now, Taylor, can you help me fix all of this? Also think in Chombalelo's introduction, I did not say that she's from Zambia. So she's joining us from Zambia. She's worked in so many different countries, and it's been amazing to have her as a partner. She's worked in Kenya, Mozambique. I'm trying to think of all the other places Chombalelo has worked, but she's going to be showing us. Yes, that's what I want. And then when she's ready, I'll pull up some things. Right. Am I still? Okay, wait. Yes. Okay, go ahead. Yeah, then I'll pull up. Okay. Take it away, Chombalelo, and I'm ready to adjust when needed.
Okay. Thank you so much, Shannon. Thank you for everyone that's joining us today. It's quite an honor to be able to share some information on supervision. So my goal today is just to take us through the stages of supervision that we have. And I think Shannon had earlier shared the apprenticeship model that we use currently. So I will start with the first stage, which is, I think, the most critical one, the practice stage. So this is where we don't have a client yet. We just have our providers go through the session guides. We call them the step sheets in most of our studies. We want them to go through each element that they got trained on and get comfortable with the steps. This is a very important stage for us because we get to work closely with the providers through role plays. There's plenty of role plays. We want them to relate to the session guides as a recipe. We usually draw it closer to something of their region so that they get to understand why we have to follow through the step sheets the way they've been designed so that they can be able to deliver quality care to the client. This stage 2 is very important because we just don't focus on the clients. We focus on the providers as well. This is where we get to learn if we have some providers that maybe have a burnout. We also get to understand if some have vicarious trauma, which is what, like a 40% rating always, that most of the providers that we work with do have vicarious trauma, and the supervision itself helps them to get the support that they need because the supervisors that we work with are trained professionals and they're able to offer treatment to our providers. We all know Doctors make the worst patients, so do providers. They don't usually know they need to get support themselves. So before somebody is ready to actually see a client, we make sure that they too are getting the support that they need. So for this practice session, the supervisor always has a practice agenda. This is very important because we kind of like have a parallel process. The supervisor has a guide throughout the session so that they're able to tailor it to what they need to get done during that session, the time that is needed. And then this in turn helps the provider to see why it's important to kind of like follow their session guide. So the supervisors have their recipe and the providers have their recipe too. So what I'm going to do now is just show a sneak peek of what this may look like, just the introduction part of the session when someone is starting out, and then we can take it up from there. So I'll ask Shannon to come on board because she'll be my provider and I will be the supervisor. So I think we on the screen, we can see the practice agenda, just kind of like what we do, the first part of it, and then just reminding the provider what I'll be doing. And then if there's a quiz that we're doing that session, then I would carry that on. And then if there's any group activity, because for practice, we sometimes have group sessions, and then sometimes we have individuals. So we have to be prepared for either one of those. Okay. So now I'm going to call in Shannon, who's going to be my provider now, the supervisor. I'll press play for us to know we're in the role play so that everybody can follow through with that. Shannon, are you ready?
Ready.
All right. So I'm pressing play because we're getting into a role play. All right. So welcome, Shannon.
Thank you.
This is our first practice group. How are you doing today?
Oh, a little nervous. It's been a busy week.
Very normal to be nervous. Would you want to share why you're nervous today?
There's a lot to learn in the training. I think this will be interesting to try to do this here today, but I'm ready. I'm excited.
I'm glad you're excited. I just want you to know that it's normal to be nervous. Most of the providers I've worked with get nervous the first practice group that we have of practice session, because I thought we'd have a group, but today it's just you and I. Are you okay that it's just you and I?
I am.
Okay, great. So I just want to walk you through what we'll be doing together each week, because you and I will meet each week for just an hour. And during our session together, I will tell you what we're doing, which I think I texted you last night to say we're going through getting active. Were you able to carry your manual, the session guide with you? Great. Okay, so we're going to go through that together. And then I'll set up a role play so that you can be able to practice, okay, using the recipe. Okay. So I will give you feedback either at the end of the role play, or I might pause the role play if you skip steps or you don't do the step correctly. Now, don't be scared. It's a learning phase. We all make mistakes when we're learning something new, right?
Yes, I think so.
Okay. All right. So take a deep breath.
Okay, and then I'm pausing it with it. Now I'm using this step sheet, right? I'm supposed to be following this step sheet, which I learned in training.
Yeah. All right. Okay, so I'm a 17-year-old, so I'll be your client, okay? So I'm a 17-year-old girl, okay? I feel sad and worthless. I stay by myself all the time and I've been lashing out. So that's me. All right. So I want you to be able to do getting active with me as your client. Ready?
Okay. So
Right. So let's get started.
You say you have trouble doing things you enjoy or important to you. Today, we're going to talk about that. What do you think you could do when you feel hopeless? What do you think you could do?
Okay, so I'm going to pause right now. So great start, Shannon. You were able to tell me what we're going to do today. Okay. So I'm pausing you right now because you were not following your step sheets.
Oh, I started with the what?
Yes, you started with a what?
Yeah.
Great. Okay. So remember what we said? We are following the recipe. I think you had shared with us in training how your grandmother makes the best chapati. So we just want to follow it from the start. What's the first thing that you need to do? The step sheets already tell you step 1. So you go through step 1, then step 2, then step 3, so that we're able to make the best dish. Okay?
Okay.
Now, not everybody gets it right the first time, so that's fine. We are here together, we've got time, and you're going to go through it. You will get it. I'm here to support you. All right. Okay. So I'll pause the role play for everybody. This is what we typically do in the practice groups. If my provider is struggling, we just normalize, encourage them to go back to the step sheets, and we go back straight into role play. Our goal is to have the providers practice. So it's practice, practice, practice till they get to a place where we feel safe for them to be able to meet with the client. So the second stage is where we actually now introduce a client. We have some forms that we use, that the providers use, to be able to track fidelity. This is very important because this is where now the scientists come in. How are we able to measure fidelity? I'll have Shannon share the tracking forms that we use. This is just one of the tracking forms that we use, but for every project, it's tailored to what the project looks like and what symptoms are being tracked for that particular case. So once we figure out that the provider is ready and they can see a client, we then prepare them. So the first thing we do is prepare the provider before they can actually meet with a client. And then they can see the client. After they've seen the client, they come back and report the session. In practice groups, we also teach them how they can write or report to us objectively. We just want to know what they did. How was the session? That helps us track track competency and adherence of the session. So what I'll have Shannon share on the screen, if she's able to find it, is one of the forms that we use on one of the studies to track the symptoms weekly for a client.
1 second, because that one was obviously messed up. Give me just a quick second.
Okay.
Here it comes. It opened at home, but it did not open here. Okay.
Okay. So as she's pulling it up, it will just show you that we're able to track the date, the duration of the session, which is very important. We don't want the providers to spend more than an hour with the client. Okay, great. So she has it down, and we always want to ensure that there's confidentiality that is followed. So we never use the client's names, our counselor's names on the worksheets. We always just use codes that are signed by the study. Okay, so as you can see, this has got the facility code. We also have the date of session. It has the duration, the session number, very important for us to track. And then the symptoms, because we check on these every week. It helps us to check the most important also, which is any safety issues, either something to do with suicidality or any form of violence in a home. So this is very important for us to check every week. And we get to coach the providers on how to use this. Okay. So what I would like to just share with you, it's also another role play where we'll have Shannon come in and report a session. So this is post, because I did show how we practice, but then now we have a provider coming in to share how her session would have gone with an actual client. So if I may have you, Professor Dorsey, for this second part as well.
And y'all are following that right. So before it was the practice group, now I've actually moved on. I've got good enough. Chombalelo trusts me to see a client. I'm seeing a client, and now I'm going to meet with her. I'm very proud of you. It's a big deal when they get to see a client. I mean, it's a really big deal. These are not easy things to learn. Okay, do you want me to pull up the Excel while I'm talking, or?
Yes, you can pull it up. But I would like everyone to follow what we'll do first so that they can see.
Oh, okay, do that and then I'll pull it up. Okay.
Okay. So now we're going to go into another role play where Shannon has actually met with her client and she's coming to report how that session went. Okay. Hey, Shannon, how are you doing today?
Doing good. I'm doing good.
Right. I'm so excited. You managed to see your client for the first time.
I know. I'm excited too, actually.
Yeah. Okay. So the first thing that I want to find out, did you use a tracking form?
I did. And
Okay.
do you want it now?
Yes. May I have that? Okay, great. So I can see you were able to fill it up correctly. I can see the date. I can see the duration and the scores. Okay. So we'll come back to the scores a little bit after you tell me what you did in session. So walk me through. What did you do in session?
Yeah, so I did the getting active, which you can see on my form. Hopefully I filled that part out.
Mhm.
It's a lot.
Yes, you did. Yes, you did.
I said what we're gonna do, the getting active. I said the why,
Mm-hmm.
explaining why getting
Okay.
active would be helpful. And then I asked
Okay.
to tell me the things that they enjoy and the things
Okay.
that, that would be our activities maybe for getting active. And they
Mm-hmm.
said they enjoy singing, playing with friends, cooking.
Okay.
And
Mm-hmm.
this client rated singing to be the easiest of those.
Okay. Okay. And were you able to assign homework?
Ooh. No, I think I ran out of time towards the end of that. We didn't get to the homework. I just kind of forgot that. At the end, I put the sheets down and I just forgot the homework part.
Okay. Okay. So thank you, Shannon, for sharing this. And what we're going to do now is look at the session guide to see if you were able to get everything down. Okay? All right. So before I even do that, how do you think you did?
It's a good question. Well, I feel good about the what and the why.
Okay.
Good about asking the symptom questions on the form.
Mm-hmm.
Client's own ideas.
Mm-hmm.
But I don't feel so good about forgetting the homework because that means she's not trying anything we talked about. So that was probably not so great.
Okay. So when she picked to do the singing as the easiest, when did she say she was going to do that?
She said she normally sings after her family has dinner.
Okay. Okay. Okay, great. So, okay. All right. So I'm going to give you feedback on how you did, and then we can plan for the next session.
Okay.
Okay. So I want you to know that when you're starting to see a client, there are times where you would actually just miss a step, but this is not where the client is actually in danger. Okay. And we can check in the client. You can just make a phone call to ensure that they're doing okay and they're doing the singing. Okay.
Well, I didn't think about, yeah, so I don't have to wait till next week. We could call her. Okay.
No, you don't have to wait till next week. We
Okay.
can just check in the client to make sure that they're doing the singing every day. Okay?
Great.
All right. So I'm going to pause the role play. Thank you, Shannon, for being an amazing provider. So as I think Shannon had mentioned earlier, as they're starting, there are certain steps that sometimes are skipped because the provider might be very nervous or the client might be in a rush. So in supervision, we take this time to go through what they did because as you were able to hear, she was very objective. She told me exactly what she did. This gives me ample time to be able to record that or rate it in the fidelity checklist that we have. So I think I'll have Shannon share the Excel sheet now so that you could see one of the forms that we use to be able to rate that. Okay. So as you can see, I'm sure that, please let us know if you're able to see this.
They'll be able to.
Okay. So on this Excel sheet, we're able to see the element that was done. And then we also have some ratings. We have adherence rating and we have the competence rating. So this is able to help measure fidelity for the session that was done. We do this for every session and we use the report that comes from the providers, hence the training of them reporting the report to be objective versus it being subjective. So supervision is a very key element because it helps us plan with the providers, coach them to be able to do as intended for each element, and they do grow and get it right. This was just our session, her first client. And then we just maybe have some struggles with some supervisors. I think Shannon had mentioned earlier when they don't have enough time for it. We have some providers that just pack the step sheets, but with supervision, we ensure that quality is delivered and there's no harm that's done to clients. So on my end for supervision, this is what I had to share just to show how we're able to train a provider from the practice to the time they start seeing cases. And this is a continuous process till they get to a place where they are ready to do this on their own. So thank you so much for your time. I think I'll hand it over to Shannon now. Thank you.
Thank you, Chombalelo. I'll just show these briefly so you can see just two things. So we're just a reminder. Sorry. This is the report. These can be simpler. We've had more detailed reports because it helps to then the supervisor can see this and move on. But this is a report the counselor did. Then we also have, sorry, because of all the screens. Here's the step sheets, the supervision, as you noted with Chombalelo, she's always walking the counselor back to the step sheet so you can see your what, you can see your why. And then, here's what I talked about. I did do this step of finding the activities, which one is easy. And the reason we have these step sheets are to make it really simple and then they can report back. But when she was also doing that practice group, just one more thing to show you since we have a little bit of time, you can see even in the practice agenda, it's looking at the step sheet, everybody writing down the what in their own words. We're not trying to get people to read directly off this, but for brand new counselors, you don't actually know how to introduce the words. I think if you already have a mental health degree, it's a very different story. But so you have an example on the step sheet, and then you get to write it down in your own words. It says quiz because we look at each person's response and see how they do, and we give them feedback. And then somebody reads through the step sheets because it's good. And then you see, this is the part I don't think I got to show you, but Chombalelo told me who my client was. And it's not as easy as it was in training. It's a 17-year-old girl who spends most of the day inside, as she said, lashes out and feels hopeless. And then I needed to do the step sheets to practice that. And then in supervision, you see she's walking me back to the session guide, which we call this the step sheet, to make sure that I followed that with my client. Okay, I'll stop sharing. All right, and so we had time for questions. If anybody has questions, Chombalelo, if you'll come back on screen, we wanted to leave a little bit of time for questions. Also, I can't believe we got through all that in the time we planned. We were very ambitious with what we wanted to. Does anybody have questions, either online or in person? Yeah.
Could you sort of define behavioral rehearsal? You
Yeah.
mentioned it as a fidelity strategy and wasn't really clear what it is.
Yeah, so behavioral rehearsal is essentially a role play, but the reason we use the term behavioral rehearsal is in the medical literature, and I'm looking to Pam, it's a more structured role play where it's someone with more experience and someone who's more of a trainee role. So you're rehearsing what you'll do in an upcoming session to get feedback. And so if you remember from the behavioral rehearsals, obviously you saw Chombalelo do tons of role plays. This is something we've done forever. But since then, just a lot of evidence is coming out to support that behavioral rehearsal is an analog to fidelity. Because if I show you how I do it in supervision, I might still not quite get it right with the client who walks in my room, but you've got a window or a picture of how I might deliver. And it's used a ton in the medical literature. Yeah, Celine.
So I noticed for the guides and the step sheets, they're very short and it's just like one sentence. Have you noticed? And then like with a lot of our mental health treatment manuals, it's like scripts of exactly what you say. Have you noticed like differences between providers with different levels of training preferring just short prompts versus like a whole script?
Great question. And I realized hopefully the question was obvious in the last one, but I should repeat it right because people online can't hear.
They should be able to hear.
Okay, online, can y'all hear the question? Just so I make sure. Okay, I'm going to guess that's a yes, but if you did not. I was asking about the briefness of the step sheets. So the step sheets we started using globally because too much writing was also hard for people, too much verbiage was hard for people, and you needed something you could use in session because you didn't have prior training. But too often, this is why I also like treatment redesign, too often I think our treatments are too complex, and those lone guides, no clinician can memorize all that to come in. The way we tried to design these, and Chombalelo and I have talked a lot about thinking about getting someone who's really good at formatting and making things pretty, which we're good at. Mental health therapy is not that. But one of the things, we try to make the bolded thing be what they need to do. And then if you need wording for it, there's examples. We've played around with boxes and things like that. But I actually think even busy mental health professionals prefer brief things. My colleague, Nat Youngbluth at Seattle Children's has developed a whole protocol called FAST, which takes a lot of our community mental health in Washington State into workbooks that are client facing, because too often therapists and providers don't have time to study up and then be in the room with the client. So everything you kind of need to know as a therapist is client facing, but teaches you. So it'll be like, let's look at this together. Behavioral rehearsal is a strategy for, but they're really brief. And even this is overwhelming. I mean, Pam, you could say from when we did, from the impact study, like, even though this is really brief, which mental health people know, it's still complex compared to other things. But I do like brevity. And then, we hope to let people do it on their own. But like even this, just choosing an activity, you still have to sometimes, if you're really depressed, break it into smaller steps. And then make sure if this client wants to do X, but do they have a way to do that? Because if not, we probably better pick something else. Then you have to plan, like she was asking me, when would my client do singing? When would you do it and where? So some of this is the way we've designed the treatment, but I think it plays into how easy is it to supervise. But I think, very few people pick up giant therapy binders. I'm always looking for something that looks like this, for sure. And these are even complex.
Question from Alberto online. How many sessions are in total on this approach?
On the supervision approach or the intervention approach? Good question.
No. Alberto, do you want to clarify that?
Well, maybe I'll speak to we see if Alberta can.
Supervision.
Oh, okay, supervision. Well, that really varies. I think, I'm going to let Chombalelo answer about PROACT, the program we're doing now in HIV clinics in multiple areas in Kenya. But for a project we did in Bungoma, where the teachers and the community health volunteers were doing a group intervention that was very structured, and they did it in groups of counselors, so someone had your back if it was a little hard. We were able to take 2 weeks to get them to practice up, and they were ready to go. But do you want to speak to PROACT, Chombalelo? Because it's many more elements and very busy HIV providers.
Sure. Okay. So for PROACT, actually, we intended to have only 2 weeks as well for practice, but then we had a pushback because the providers are so busy. There wasn't we didn't have enough time with them. We kept on repeating the session. So we took close to 2 months for most of the providers, and we still had some more spend a bit of time in practice as well. So I think it was a new group that we were dealing with that are just so busy and overwhelmed with the other responsibilities that they have, so that we did have a pushback on that. So, and then the intervention itself supposed to be between 5 to 6 weeks, which we're able to deliver for most part of the study. But then we also had those that were able to run for 9 weeks, because some providers just, not that they were weak, but it was just so overwhelming, because I think last year we had a lot of things going on with contracts ending, funding, and everything else that was, attributed to that. So I think with every study, we can put a timeline, but then we're hit with so many obstacles that come and unforeseen, and then we just have to kind of like problem solve and make the best that we can. Yeah.
I have a question about for the providers, if there is space in your intervention for personal development. In my work with clinicians, I'm a therapist, and as I provide supervision, I know that the provider's own personal development is very important for their professional work.
Yeah.
And usually it's what impedes them from growth and being able to sit with their clients. And I'm just curious for your intervention, where is the space for the personal development piece?
That is for Chombalelo, because she is beautiful. This is one of her deepest skills. Will you speak to that, the personal development, the self-care for the counselors? Did you hear it?
Yeah, so okay, thank you so much for that great question. I think this, I had mentioned it earlier, the critical part of when we start the practice sessions, we start building from there, because we do notice that everybody comes in with different struggles and challenges. So we just don't focus on the quality delivery that has to be done to the clients, but we build them as well with what is needed. So self-care is like one of the first things that we really focus on, because if a provider is not in the right state of mind, then we know they cannot be able to deliver quality. And then kind of like just even looking at the skill enhancement that we do, in as much as you're delivering therapy, you should be able to do reports. Those are things that they never anticipated they would actually learn on how to be able to write an objective report, and making sure that it's in summary form, because most of the lay providers we learn don't even have any form of training at all. So it's at that stage that we start building that, and it's an ongoing thing till they're done with the study.
And the other thing is with the practical skills, the other thing I see Chombalelo do with almost all of them is teaching them to use the skills they're going to use with their clients in their own lives, but also how to not carry home the trauma of the clients. Because, you know, so much of that in supervision, you just go home worried about your client. And the more you worry, the less able you are to serve someone the next day. So I know many of you experience this, but in the Project ProAct that Chombalelo is talking about, every single counselor retrained and every single clinic lost their job, because underneath it all, they were USAID funded. So we had everyone lose their jobs, get fired and laid off. Some of them came back and wanted to volunteer delivering ProAct because they thought the intervention was so critical for the youth. And we were able to take some time. The study was able to pay Chombalelo to provide well-being support for all of those counselors, along with another team of trainers who are all Kenyan, because the impact of losing your position and everything else. So I'm so glad you said that, because it's not just the treatment, it's holding and the care for the providers so that they can, like the oxygen on the plane, you know, the mama first and then the baby, so that you can make sure they deliver well.
Yeah, I just want to piggyback. My name is Judy. I want to piggyback on what she said or asked. You said earlier that fidelity, in measuring fidelity, there's an aspect of maybe assessing the resources available, and sometimes if the resources are not available or limited, then one can shift to having a less complex intervention. So I was just wondering how in providing probably development skills, where entrepreneurship skills can kind of work. I'm also a mental health counselor, and at some point I have seen integrating some kind of entrepreneurship skills within like the healthcare settings for providers, maybe for the clients, sometimes has helped to, you know, like in terms of sustainability of an intervention. I don't know, just speak a bit into where that would play in addressing the resources.
Yeah, let me ask you, when you say with entrepreneurship, like raising some funds, is that kind of what you're thinking about, or?
Yeah, like maybe a practice that I did was like getting like skills that people already know, like bead making or other livelihood skills, kind of being shared or learned as part of therapy or group therapy.
And one more question, sorry, as an intervention or as a way to, like as a relaxation intervention, or more as a way to get money to sustain the other intervention?
Both of them.
Both, okay.
Relaxation, but also in the end, teaching some skills which could also help like sustain that intervention.
Right. So, you know, when you saw the step sheets, one of the things, because if you're going to move this to a different cultural context, you never know what somebody finds. Like I'm not, like Chombalelo doesn't know in Kenya, I don't know in Zambia, you know, so we always start with what people like and already do. But Clara Johnson, who I showed on one of my slides, did a social determinants of health intervention alongside the intervention in Bungoma. So people, the youth and the families was for orphan kids, but they could raise money that would help the families who were saying we need not just the mental health therapy, but we also need money for school fees and uniforms and things like that. So she did it at the client level so they could do some shared money, but I hadn't thought about it at a facility level to raise a little money, or at a counselor level to support the intervention. So we haven't done that, I don't think, unless Chombalelo, have you done it in a different project?
No.
But I love that idea.
Yeah.
And I also know we're at time, so I'm happy to stay for questions, and Chombalelo can stay a little too if we have the room a few more minutes. But I did want to officially wrap it up and thank everybody so much for coming and for listening.